I'm going to present you another interesting live-in-a-box case, this time involving the transcatheter closure of a paravalvular leak in a patient with an aortic mechanical valve. So our patient is a 63-year-old male presenting with progressively worsening exertional dyspnea, along with clinical and laboratory signs of hemolytic anemia. His medical history includes arterial hypertension, COPD, and an episode of infective endocarditis in 2016, leading to the need of surgical aortic valve replacement 4 years later in 2020 with 23 millimeters Sorin bicarbon mechanical prosthesis. Immediately post-operatively, he required the replacement of a pacemaker due to conduction abnormalities. In January 2025, the patient was admitted with a respiratory infection, and during this hospitalization, laboratory workup showed an hematocrit of 22%, very high LDL and very low aptoglobin levels, findings compatible with hemolytic anemia. At the same time, transesophageal echocardiography revealed moderate aortic paravalvular regurgitation, so the patient was referred to our department for further evaluation. The transthoracic echocardiogram performed in our department, as shown here, demonstrated preserved LV ejection fraction of 50-55% with normal disc motion in the mechanical valve, and confirmed the presence of a moderate paravalvular leak at the region of the left coronary cusp with a vena contracta of 3 to 4 millimeters. A transesophageal study with 3D imaging was then performed, which better highlighted the exact location of the leak in the left cusp, as well as its crescent shape, suggestive of a relatively narrow and irregular tunnel. The next examination performed was a CT scan, which, as you can see, provides us with additional information regarding the shape, the length, and the width of the tunnel, the calcification in the area, and the distance from the origin of the left main, all of which are crucial for optimal management planning. The same are visualized here using multiplanar reconstruction. Based on all the above and taking into account the patient's history, the heart valve team of our hospital opted for a transcatheter closure approach as the optimal strategy for this patient. So the next step is the selection of the appropriate closure device. In general, there are two main devices available for transcatheter PVL closure: the Amphitheatre vascular plug 3 and the Occlutech paravalvular leak device. The Occlutech paravalvular leak device is available in square and rectangular shapes, and each shape is available in two configurations, one with a central waist and one called twist, which has no waist and offers greater flexibility in irregular or calcified defects. Each variant of Occlutech devices comes in a wide range of sizes, as you can see here. And the Amphitheatre vascular plug 3 device from the other sides come in 9 different sizes and has a multi-lobed structure that adapts better to smaller circular or central leaks. In our case, based on the crescent shape and the rather irregular and sure calcified tunnel, we chose the rectangular twist device by Occlutech, while the size selection was based on echocardiographic measurements taken during the procedure. So we move on to the live case. I will describe the steps during the live video. In general, the procedure was performed under general anesthesia with TOE guidance, and femoral access was obtained bilaterally with echo-guided puncture. As you can see, Okay, as you can see, a 10 French sheath was placed in the right femoral artery, and 7 French sheath that you can see here is placed in the left femoral artery, through which a 6 French pigtail catheter was advanced into the aortic root for angiographic guidance during the procedure, as you can see. So initially, let's move on here. So initially, we used an AL1 6 French catheter to successfully cross the paravalvular defect with a straight wire, as you can see. We managed to cross the defect, the leak, with a straight wire, but the AL1 catheter itself could not be advanced through the track, as you can see here. Therefore, it was removed and exchanged for a 5 French multi-purpose catheter, which was able to advance further into the tunnel. I'll try to show you the step. Here. So the straight wire was then removed, and through the multipurpose catheter, a Landerquist wire was advanced into the left ventricle. Here is already advanced. This is, I don't have a pointer. Ah, okay, I don't have. We have inserted the, okay, I can show you. But here we have inserted the multipurpose and the Landerquist through this catheter. Next, after echocardiographical measurements of the defects, the appropriate device size selected was a 5 French, I'll tell you later, but this size needed a 7 French occluded delivery system, which was introduced via the right femoral artery. Here we can see the insertion of the sheath. So then, after removal of the dilator, the occluder device is advanced through the sheath. As you can see here. You see the sheath, and we are waiting for the deployment of the device, the advancement. Okay, here the device is advanced, and the one disc is extracted into the left ventricle, and then the whole system is pulled back as you can see. Until it reaches the outflow of the leak. Okay, so I'll show you again this step. Then it has reached the outflow of the leak. And the next move is to deploy the twist segment and the other disc to the aorta, as you can see here. This was our first attempt, and the second disc was not very well deployed was deployed within the tunnel. So we recaptured the device and we attempted redeployment in a more optional position. Here you can see the redeployment. Here. So this step can theoretically be repeated multiple times until satisfactory positioning of all parts of the device is achieved. At this time, the device appears to be in good position, and after confirming its stability and being satisfied with the echocardiographic reduction of the regurgitation, as well as the observed increase in the diastolic pressure in aorta, the device was successfully released. Somewhere here. Okay, we released the device. So the procedure was completed with a close of the right femoral vein using a prostyle, and the left femoral artery using an angiosin. At 1 month follow-up, the patient showed marked clinical improvement, and although echocardiographically still detects a small to moderate paravalvular leak, as you can see here, patient reports minimal exertion dyspnea, NIHA 1 to 2, and his hematocrit has been improved to 40%. So in conclusion, I will tell you some things about aortic paravalvular leaks. Aortic paravalvular leaks are more commonly seen following transcatheter valve implantation compared to surgical valve replacement. According to the data shown here, after surgical aortic valve replacement, the incidence of PVL is reported between 1% and 5%, while after TAVI, mild PVL may occur in up to 30% of cases, and moderate to severe PVL is seen in 5 to 15, depending on valve type and operator experience. Etiologically, PVLs result from incomplete annular sealing, calcification, or sutured adhesions. When moderate or severe, are independently associated with increased mortality, underscoring the importance of early recognition and appropriate management. 3D TOE is the gold standard for diagnosis, while CT complements complex cases. Surgical reoperation is the gold standard, but transcatheter closure offers more than a 90% success and low procedural risk in appropriate candidates. Thank you for your attention.
Very nice, Dr. Perlepe. So this presentation is open for discussion, and I have to remind the colleagues that they are streaming. We have 314 now streaming. So feel free to ask anything on the chat box. Dr. Nignos, you have a lot of experience in paravalvular leak closure, right? So maybe the Transbalkan Center is doing the most in Greece right now. We don't know. So I think they're pretty rare in Greece. But they should be a lot more frequent, because a lot of these patients, end up doing a reduced surgical approach, and we know that this care has an inherent increased risk of complications. So we notice in this this is the only the Oculoc device is the only specifically designed for paravalvular leak closure, and maybe, of course, there are some caveats. There are some the sheath is more burdensome to manipulate, but I think I think it's a good depiction of how to close paravalvular leak closure. How long do you have to wait in order to see a complete, let's say, so as long as you are successful? How long do you have to wait for complete endothelialization to occur and then see a meaningful decrease in the paravalvular leak?
Very much again for the invitation to be here, part of that wonderful meeting. I think that the story with the paravalvular leaks is a very frequent one. I mean, there are a lot of cases, as you mentioned before, and a lot of patients also have hemolysis, and that's a very bad thing. They require blood transfusions, and that's, of course, those patients can be reoperated and then have again a relapse. I don't know why, but we have seen that before. Sometimes it's enough to modify the leak, not to have a perfect result. And the modification of the leak can be enough to stop the hemolysis or to improve the functional status of the patient.
And which are the situations that you don't actually touch when you have a rocking valve, or when you have a lot of do you have like exactly. 180 degrees and exactly. More
yes, a rocking valve, or if the ring is detached, of course, that's another story. But if there is a paravalvular leak or two, then you can try. It's deserved to try. I would wait for 1 month to evaluate the result. And sometimes somebody can be disappointed initially because the color Doppler shows some color, and somebody can say, okay, I don't have a good result, but it's not the time to evaluate during or immediately after the procedure. You have to wait and evaluate clinically the patient and echocardiographically after 1 month.
Okay, good. And I see Dr. Zarogiannis, do you have experience in paravalvular closure? How do you deal with in this setup, right? Okay, good. Excellent. So any other comments from co-moderators? Vaso?
Yes, I would like to ask how many times after the first deployment of the device could you deploy a new one if the residual regurgitation is,
I mean, other than immediately?
Moderator.
Of course, you can place immediately, but you can wait and see. But there's always the case that you might have a dislodgement or compromise of the metallic or valve. You always have to be
concerned about
exactly,
the metallic
yes.
valve and the discus. Yes.
Good. So thank you, Dr. Perlepe.